In Chapter 10, we talk about our analgesic drugs. For our analgesic drugs, we're really managing our patient's pain. I do want you to consider the chapter objective number 8, where we realize there are some non-pharmacological management things that we can do for a patient, such as that's experiencing pain. That could be a massage, a hot pack, a cold pack, deep breathing, meditation, visualization. So do consider some of the other things we can do for our patients with pain. But for purposes of this chapter and to get you ready for HESI and NCLEX in practice, we want to talk about our analgesic drugs. So read through your objectives here and then scroll through your key terms, because a number of these will come up throughout our chapter as we talk about our analgesic medications. When we look at these medications, we're basically looking at these different drugs as we use those for analgesia purposes, specifically to minimize our patient's pain. I want us to get into our head that there are two basic groups of drugs in this chapter that deal with analgesia, and I've put up an outline if that helps you. The first group of drugs are our opioid drugs, and the second group of drugs are our non-opioid drugs. So when you look at the ones I have listed on a chapter outline, these are the ones that we typically use the most common, and all of these have an opioid component to them. Healthcare providers are trying very diligently to not prescribe these as much as we have formerly, because we do realize we have an opioid addiction crisis within our nation. So they are trying to minimize use. However, do understand that sometimes they are the drug of choice for specific pain, especially when we're looking at an individual post-surgery. So when I have someone that needs a pain medication, we first want to make sure that we're talking about their pain, we're assessing their pain in the first place. Pain is subjective, so it's whatever that patient tells me it is. And almost all of our facilities will use a numerical scale to have that patient rate their pain. So if 0 is the worst, or 0 is absolutely absence of any pain, don't have any pain, and 10 is the worst pain you've ever had, tell me what your pain level is right now. So we're going to ask our patients to assess that pain, and then they can give me some other adjectives, if you will, about how that pain is impacting them. Is it radiating? Is it crushing? Is it burning? So see if they can give you some examples on what that pain feels like to them, as well as what causes that pain. Does your chest hurt and you have radiating pain if you're doing exercise or activity, or does your left ankle bother you when you put pressure on it? So see if we can define, get as much information about our assessment on that individual when they're discussing their pain with us. When we look at our opioid treatments, I want to hit a couple of things very right off the top. We're under the classification of CNS depressants. So all of the medications in this chapter depress that central nervous system. So think right off the bat, if I'm giving pain medication, I want to assess my patient's level of consciousness, how alert are they, and their respiratory rate. Those two things are paramount because as my medication takes effect and it starts to decrease their pain level, which we mentioned a little bit earlier with our pain scale, we're also going to see a decreasing respiratory rate, and we can also see a decreasing or a change in their level of consciousness. So we want to make sure that we're aware of that, and we also need to be cognizant that sets our patient up for a fall risk, especially if it's an older adult. So keep that in mind. When we look at our opioid medications, do be aware that some of our patients can develop a tolerance for those medications, and as they develop that tolerance, we have to use higher and higher amounts to get the same pain level down as formerly. So we might have used 10 milligrams formerly, and now that's not working because they've developed a tolerance to it. So now we might have to use 12 milligrams of that medication. So that's what that tolerance part needs. We also in this chapter discuss PCA, which is a patient-controlled analgesia. That patient-controlled analgesia is typically through their IV line, and it allows the patient to control when they want their medication. So they can push a button and it provides them with that medication. Now, the nurse sets that up for the healthcare provider's parameters so that they don't get too much of that medication. And once they've received their dosage that they're allotted, it locks it out for a time frame based on how the nurse entered that into the PCA pump. The benefit of the PCA pump is that when we give individuals the independence to select their medications, they typically use less of the PCA, even though it's available to them, which is kind of an interesting thing. So they'll usually use less of that medication. Another opioid issue we need to be aware of is the adverse effects that come with our opioids. One of the number one problems that we see when our patients have opioids is, besides the tolerance they can build up, is constipation. So anytime I'm giving an opioid, I'm going to teach that patient about the potential for constipation. So you're going to hear this all semester. So what we want to do with those individuals is increase their fluids, so force fluids, increase their fiber, so see what we can do in their diet to have fiber, and walk, all activity, all those three things. So fluids, fiber, and walking will help to decrease that constipation that's usually associated with our opioids. That tends to be a really common, not only problem, but a question that comes up with those medications. When we look at some of the specific medications that our textbook takes us through with these medications, they all bind with the brain to decrease that pain sensation. Typically, we'll give our opioid medications when my patient complains of pain that's severe at or above a 5 on that 0 to 10 pain scale. Another indicator for opioids is actually chronic cough. So if an individual has a chronic cough, they might be prescribed an opioid, but we want to make sure that that cough is a non-productive cough. In other words, it's just a dry, hacking cough that they can't seem to get rid of that's usually impacting their sleep, that opioids can be used for that as well. Our contraindications for our opioid are typically drug allergies, and I'll say that all throughout the semester, but a drug allergy or any type of respiratory insufficiency. So think about individuals with asthma or a chronic respiratory problem. They would not be good candidates because we know these opioids decrease their respiratory rate. Some of the adverse effects that are associated with our opioids is a really good table right here that show us some of those. Hypotension, so it's going to drop that blood pressure. We can have bradycardia, so slowing down that heart rate. Look at that central nervous system. We can have sedation, disorientation, lightheadedness. Again, we mentioned some of those things with that GI tract, constipation being the biggest one here. We can have some urinary retention, and we can have that respiratory depression. So when you think about these, think about we're slowing down that respiratory, or that we're slowing down that central nervous system. So these are the things that we'll see with that depression. If I have an individual that has a overdose of opioids, we can give them a medication called naloxone, which binds the receptor sites and it doesn't allow that opioid to be utilized. We use that naloxone or Narcan for our opioid overdose, and we have a similar word, naltrexone, for alcohol addiction and opioid addiction. So it can help individuals that are trying to break their addiction to those medications. So Narcan or naloxone is our for use with my opioid overdose. Scrolling through the very end of the channel when we're looking at some of our drug profiles that are our opioids, I want you to consider some of these things. Traditionally, when my patients take codeine, one of the side effects of that is that upset stomach, so we're going to encourage that individual to take it with a small amount of food. I usually think about a more of a high carb food like bread or crackers to take it with, to decrease that gastrointestinal upset. If I have a patient on fentanyl, Fentanyl is a 72-hour patch, so I can leave it on for 72 hours, change it every 72 hours. It takes about 6 to 12 hours for that first onset of pain relief, but then it can last for a considerable amount of time, 72 hours while it's got the patch on. It can even last 17 hours after removing that patch. Nurse prerogative on this one is to ensure that when you're putting on a new patch, that you take off the old patch and dispose of it properly. Keeping scrolling through some of these. Hydromorphone is another medication that we see frequently in the hospital setting. Be aware that this one's very potent. I believe it's 7 times more potent than morphine, so be aware of the severity of that one. So you'll want to, when you see a dosage on this one, if it looks high, you would want to question that dosage to ensure that it's the correct safe amount of medication. Methadone hydrochloride is our next one, which is Demerol. So methadone hydrochloride, we can use this one to detox our opioid addicts, and we can also use it post-surgery for pain relief. It may cause dysrhythmias, so on this one, in addition to monitoring their respiratory status, I'm going to monitor their heart rate also. Morphine sulfate, let's see, I'm going to go down to this one, morphine sulfate. We usually use this one for severe pain. The negative aspect is it has a very high abuse potential. We can give it in a couple of different routes, so it can go sub-Q, IM, IV, and we have to use it very cautiously with our renal patients. So for anyone who has any renal kidney problems, we would use it very carefully with them, which means if we did use it, we'd want to monitor their urinary output and ensure that it's at least 30 cc's an hour. And I believe our last one here is our oxycodone hydrochloride, which we can use in either an immediate release or a sustained release. Moving on to the non-opioid analgesics, these would be favored when an individual isn't experiencing such acute pain. So if it's usually less than a 5, we would like to use our non-opioid medications. We're going to hit on 2. So we mentioned our indications for this one being that mild to moderate pain. Also want to note that it's useful for treating fever and pain, especially in children. It's a great option for fever in children. Adverse effects of our non-opioids, especially Tylenol, is that it can be lethal and cause liver issues because of the toxicity with our liver. So I want to make sure that when we look down here at our acetaminophen, we note that usually we want to avoid taking Tylenol with alcohol, and then we want to watch that cumulative dose. So making sure they're not exceeding that dose per day or how much they're supposed to have in a 24-hour period. Right above the Tylenol, I wanted to point out the antidote for a Tylenol overdose, which is this acetylcholine. One of the things about this was it smells really bad when we give this one orally, but it does help bind with that Tylenol. So if I've got someone that comes in with a Tylenol overdose, we'll be giving this acetylcholine. I can't say it, excuse me. And it does have that really bad odor. We do want to encourage individuals that are under the age of 12 to not take aspirin for pain. We want them to take Tylenol for pain because aspirin for pain in children under the age of 12 is associated with Ray's syndrome, which looks like kind of like a flu, and it can actually cause pediatric deaths. The last thing I want to do in this chapter is have you scroll to the end where we talk about the nursing process. Pay attention to the assessment, what we're assessing prior to giving those medications. So think about respiratory status, level of consciousness, blood pressure, and then also think about liver function. We want to make sure their liver is working well prior to giving our analgesics, especially our Tylenol. And then I want you to scroll down to it even separates it out a little bit better. I want you to scroll down to the implementation. So one of the things we want to make sure we're doing when we're giving our medications, having our patients rate their pain before we give the medication, and then coming back to assess that pain after we've given the medication also is very important. And then that goes right into our evaluation of these medications. Oh, let me scroll down real quick. Our evaluation of how our patients are tolerating the medication. So again, think of some of those things such as constipation, how do I avoid that? If they're feeling really drowsy, if it changes their level of consciousness, preventing those falls and making sure we're monitoring for that.